This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Elara, Research Fellow. Today we're looking at a fascinating new study from the journal PeerJ, published in 2026, titled A Prediction Model for Thrombocytopenia After Neurosurgery, a retrospective study.
This is a topic that hits home for anyone who spends time in the NICU or the OR. We often see platelet counts drop after major cases, but we haven't always had a clear, validated way to predict which patients are at the highest risk. Elara, why is this specifically such a catastrophic issue, to use the author's wording, in our field compared to, say, general surgery?
That's exactly how the authors, Zhang and colleagues, frame the problem. They point out that while postoperative thrombocytopenia is common across many specialties, the neurosurgical population faces unique risks. First, the brain parenchyma is incredibly rich in tissue factor, or TF. When we have a traumatic brain injury or we're resecting a tumor, that TF is released into the systemic circulation. This triggers the extrinsic coagulation cascade, which can lead to a profound state of consumptive coagulopathy and platelet depletion.
Right, and unlike a hematoma in a thigh or the abdomen, even a minor secondary intracranial hemorrhage, an ICH, caused by low platelets can lead to rapid neurological deterioration. The authors mentioned that normal hemostatic function is crucial because the consequences of even minor bleeding are so severe.
Exactly. And while there have been models for cardiac surgery, this is actually the first study designed explicitly to predict thrombocytopenia in neurosurgical patients. They looked at 1,109 adult patients who underwent invasive neurosurgical interventions at Dongyang People's Hospital between 2010 and 2020.
That's a decade of data. It's quite a broad cohort, too. Everything from major craniotomies to burr hole drainage and EVDs. Before we get into the model itself, what did the descriptive data tell us about the impact of thrombocytopenia on these patients?
Out of those 1,109 patients, 103 developed thrombocytopenia, which is an incidence of about 9.3%. The clinical outcomes were significantly different. Patients who developed thrombocytopenia had a longer hospital stay and a longer duration of mechanical ventilation compared to those who didn't. The study reinforces that this isn't just a lab value. It's a marker of profound systemic dysfunction and physiological decompensation.
So they used a logistic regression model to try and predict this, but they didn't just throw every variable at the wall. They used lasso regression first, least absolute shrinkage and selection operator. For our residents listening, that's a way to prevent overfitting by narrowing down the most impactful variables. Elara, what were the final 8 predictors that made the cut?
The 8 predictive variables were quite a mix of clinical and laboratory data. We have hypertension, the SOFA score, sepsis-related organ failure assessment, serum total bilirubin, albumin, international normalized ratio, INR, thrombocytocrit, the first measured systolic blood pressure, and the use of vasoactive drugs.
That's an interesting list. Some are intuitive, like the SOFA score and vasoactive drugs, which suggest the patient is already systemically ill or in shock. But the inclusion of thrombocytocrit and albumin is interesting. Did the authors go into the why behind these?
They did. They noted that the SOFA score is already a well-known independent predictor of mortality in the ICU. Regarding albumin, they mentioned that low levels can be a sign of malnutrition or a systemic inflammatory response, both of which can impair platelet production or increase consumption.
And the inclusion of INR and bilirubin highlights that hepatic function and the overall coagulation profile are inextricably linked to platelet health. Now, let's talk performance. How well did this model actually work?
It performed remarkably well in terms of discrimination. They split the data into a training set and a test set. In the training set, the area under the curve, the AUC, was 0.916. In the test set, it held up well with an AUC of 0.883.
An AUC of 0.9 is excellent for a clinical prediction tool. That suggests it's very good at distinguishing between who will and who won't get thrombocytopenia. But I noticed something in the paper about the recall.
Good catch. While the specificity was very high, over 0.9, meaning it was great at identifying those not at risk, the recall was lower. It was 0.414 in the training set and 0.364 in the test set at a cutoff value of 0.5.
Let's break that down for the residents. High specificity means we aren't crying wolf often. If the model says you're low risk, you probably are. But low recall means it only caught about 36 to 41% of the actual thrombocytopenia cases at that specific threshold.
Correct. However, the authors also performed a subgroup analysis on patients with acute brain injury, or ABI. This is where the model really shone. For the ABI subgroup, the optimism-corrected AUC was 0.905, and the precision improved from 0.545 to 0.664. This suggests the model might be even more reliable for our most critical trauma and stroke patients.
That's a vital distinction. In those ABI cases where we're dealing with that massive release of tissue factor we mentioned earlier, having a tool that helps us intervene early is huge. The paper suggests this can serve as a clinical decision support tool for early intervention. What kind of interventions are we talking about here based on the paper?
The authors emphasize that early identification allows for closer monitoring and potentially earlier correction of underlying factors. If we know a patient has a high SOFA score, is on vasoactive drugs, and has a rising INR, we might be more aggressive in our management before the platelets hit that catastrophic threshold. They also point out that patients who recover from thrombocytopenia during their ICU stay have a decreased rate of in-hospital mortality compared to those who stay thrombocytopenic.
It really highlights that we need to view the platelet count not as an isolated hematologic issue, but as a window into the patient's overall physiological stability.
Exactly. And it's worth noting the exclusion criteria they used to make the model clean. They excluded patients with cirrhosis, hematological malignancies, and known heparin-induced thrombocytopenia, HIT. So this model is really designed for the standard neurosurgical patient who develops this as a post-operative complication rather than a pre-existing condition.
Looking at the big picture, the study admits it's a retrospective analysis from a single center, which is always a limitation. But with over 1,100 patients and such a high AUC, it provides a very strong foundation.
It does, and they use the calibration curves to show that the predicted probability closely matched the actual observed frequency of thrombocytopenia. So the model isn't just discriminating well, it's accurately calibrated.
This is the kind of research that bridges the gap between the lab and the bedside. If we can use these 8 variables, many of which are already in our standard admission labs and vitals, to flag a high-risk patient in the first few hours after they leave my OR, we can potentially change their trajectory.
Absolutely, especially for those ABI patients where the precision was higher. The study concludes that these logistic regression models have the potential to be integrated into clinical workflows.
Well, this has been a great deep dive. To summarize for our listeners, post-operative thrombocytopenia occurs in nearly 10% of neurosurgical patients and is linked to longer stays in ventilation. Using 8 key variables, hypertension, SOFA, bilirubin, albumin, INR, thrombocytocrit, systolic BP, and vasoactive drugs, we can predict this complication with a high degree of accuracy, particularly in acute brain injury cases.
Thank you for joining us on the Neurosurgery Hub Podcast. We'll link the full PeerJ study in the show notes.
Until next time, I'm Dr. Aris.
And I'm Dr. Elara. Keep learning and keep operating safely.